When Tom Zeller was in his early 20s, he was living in Finland and teaching English to kindergartners. He had no idea this classroom would be ground zero for a battle he'd be fighting the rest of his adult life.
I was just sitting there, and all of a sudden, this thunderbolt of pain just kind of grabbed the right side of my head as I was sitting there in the classroom and just pinned me to the floor for about, it was very short, maybe like 30 seconds. And I thought, oh, I mean, I'm having a stroke. Something is terribly wrong.
Zeller had just experienced his first cluster headache. Unfortunately, it would be the first of many. Zeller describes it as one of the worst pains a human can experience.
I liken it in terms of pain intensity, which is the main factor in a cluster headache, to having your hand on a hot burner, but not being able to take it off. So it's that level of pain. It's kind of an emergency, but you can't stop it. So a person in the throes of a cluster headache cannot sit still like a migraine nurse often will put their head under a pillow and seek a dark place. While as a cluster headache attack, you're pacing, you're rocking, you're banging your head, you're writhing on the floor. It's not a pretty episode to witness, but you definitely cannot sit still. The pain is that intense.
Cluster headaches are a rare disorder. While men are more likely to have them, women tend to experience more severe effects. The cluster headache gets its name from the fact that people can experience up to 8 attacks in a 24-hour period. Each one can last anywhere from 15 minutes to 3 hours.
This happens relentlessly for weeks at a time, maybe for 2 months out of the year, and then like magic, they just stop and they're gone. And not by anything that I've done and not by any medication I've taken, they just turn themselves off. And if we could figure out why, we'd cure all of us. For some people, there is a rhythmicity to it. You can kind of expect that you might get it at sort of the same times of day or night. I often would get mine immediately upon falling asleep, and I would be thrown out of bed by, basically a stroke of a headache. But it's not perfect. It's not perfect enough to be predictable. So some patients get them in the fall and the spring more often than not, but then they'll just as likely get one in March for no reason that they can explain. So it's not something you can plan for.
Research shows that for many people, these headaches become less frequent with age. Thankfully for Zeller, this is looking to be true for him as well.
They've actually started to wane as I approach, I'm 56 now, so I'm approaching 60, and both cluster headaches and migraines can often start to wane as you age, which is a clear indication that there's a strong hormonal component to all of this too that we don't fully understand. But, it's clear that hormones are involved in many migraine patients. Women will often get their worst migraines around their menstrual periods. Women who go into menopause often see their migraines magically disappear. So there's definitely a strong hormonal component. And I think it's true for cluster too. As you age, hormones ebb and flow, metabolism changes. So I feel like, I'm always wary of saying this out loud because who knows, I'm tempting fate, but I feel like I'm aging out of the worst of it. I hope it's true.
Zeller writes about cluster headaches, migraines, and the common tension headache in his book, The Headache, The Science of the Confounding Affliction and a Search for Relief. People all over the world have been suffering with headaches and migraines for thousands of years. Researchers believe skulls from 7000 BC featuring a hole in the crown are evidence of healers trying to relieve their patients of headache pain. Today, up to 70% of the U.S. population experiences the common tension headache on a regular basis. 47 million Americans suffer from debilitating migraines, and over 340,000 people in the U.S. experience cluster headaches. Despite the pain being in the same area of the body, Dr. Amal Starling says the experiences are vastly different when comparing the three.
One differentiating factor that is very obvious between people with cluster headache and migraine is that in people with cluster headache, they have this physical restlessness where they have to move. So if you can look at YouTube videos of people during a cluster attack that have filmed themselves because they're wanting to share with others what it looks like to have a cluster attack because it's so severely unrecognized and underdiagnosed, even by clinicians and physicians. But you'll see that people are rocking, they're holding their head and rocking back and forth. I still remember the very first patient that I saw as a medical trainee. I was a resident having a cluster attack during one of my office visits with the patient, and they jumped up out of their chair when the attack started and they started pacing around the room. And this very kind and soft mannered gentleman then ended up punching the wall, and their hand went right through the drywall because they had this physical restlessness that's present during a cluster attack.
Starling is a headache neurologist and consultant at Mayo Clinic in Scottsdale, Arizona. Despite this burden of need for medical intervention, relatively few doctors, less than 900 in the U.S., choose to specialize in headache medicine.
That's very directly correlated to the amount of funding that is available. Because if there's less funding, there's going to be less scientists in that space.
Starling says the disparity between the burden of care and the current federal funding for headache research has concerned headache specialists for decades.
Not only are there, a high prevalence, meaning a lot of people who have migraine and other headache disorders, but the disability that is related to the disease burden is huge. So based on the Global Burden of Disease study in the World Health Organization, migraine is one of the leading causes of disability worldwide. Specifically for women, migraine disproportionately affects women. 1 in 5 women have migraine. And in women ages 15 to 49, it is the number one cause of years lived with disability based on the World Health Organization.
The NIH budgets $20 million annually to headache medicine research. That may sound like a lot, but Starling says it's disproportionate to the number of headache patients.
If we were going to actually fund diseases based on their disease burden, that number should really be about 7 to 10-fold what it actually is, closer to about $200 million per year. So there's just a huge disparity in funding.
Starling believes the reason for this disparity is an age-old bias towards both general pain disorders and women's health.
In general, pain disorders are often funded at a much lower rate than other conditions like autoimmune conditions or dementias or cancer. And then there's a lot of stigma in diseases that affect women more than men. And that's been demonstrated in, perimenstrual disorders, endometriosis, maternal mortality and health. And that same applies with headache disorders and specifically migraine, which disproportionately affects women.
And while it's true that people don't die from headache pain, it's also true that those who suffer from migraines and cluster headaches experience a much higher rate of suicide compared to the general population. Imagine how hard it is living with an invisible condition that can debilitate you at any moment. It's so intense that Starling says it's common for people to run to the emergency room after their first attack.
They feel like their world is coming to an end and they have a catastrophic brain tumor or brain bleed or something that is, life-ending. And so they'll end up in the emergency department. And often at that time, they may end up doing a CT scan of the head and they find that there is no blood in the brain, and they may find that there is no brain tumor. And then they often tell people, well, your brain looks fine. And again, it's a short-lived attack. And so then they may come back to their baseline and they're often just discharged from the emergency department saying, we didn't find anything. Your brain looks okay.
When Zeller experienced his first cluster headache that pinned him to the classroom floor, he thought he was dying. He went to a doctor and got a CT scan, but it showed nothing wrong with his brain.
It's probably only a cluster headache patient that is incredibly disappointed when they have a brain scan and they don't find a tumor. Because you're left with this mystery. Like, if it's not a tumor, if there's not something in there that you could photograph, that you can scan, that you can show is causing this, then I've got nothing. All I have is, this pain and my word, but nobody can see it, and no one will ever be able to see it.
The reason the brain scan looks normal is because cluster headaches and migraines are not disorders of brain structure, but rather disorders of brain function. Starling says it's often the case that emergency room providers and primary care physicians aren't even aware of cluster headaches. And since that's the first place people think to go, it often means that these patients suffer for years without a diagnosis or treatment.
Eventually, maybe they get referred to a neurologist who is trained at providing these diagnoses. And then eventually they may get to a headache specialist that has additional expertise in treatment. So it is a long road, and we have studies that show it takes many years before cluster headache can be diagnosed. And with migraine, it often is many years before individuals receive a diagnosis as well as treatment options as well.
To remedy this lack of clinical awareness, the American Headache Society has developed a program called First Contact.
And we're trying to provide more education to those clinicians that are on the front line as to how to screen for these diagnoses, how to provide the clinical diagnosis, and even initial treatment options that may be effective for a large cohort of patients before they're then able to get referred to a neurologist or a headache specialist.
While there's no cure for any type of headache, there are various treatments. However, Starling says personalized medicine is essential to effective treatment for all headaches.
Migraine specifically, and many other headache disorders, but migraine is a genetic neurologic disorder. But it's not as simple as saying there is one gene and one gene mutation that leads to migraine. But the genetic research that we have to date identifies that there's over 100 different genes and hundreds of different genetic mutations that can lead to vulnerability to developing migraine, the genetic neurologic disease. And so that is why everyone with migraine may have a different combination of these genetic mutations on these various genes, and their migraine disease might be slightly different.
Sadly, Starling says it's an area that lacks funding, which is precisely why she and other headache specialists are advocating for headache research on Capitol Hill. Their proposed bill, called the Headache Act, aims to improve prevention, timely diagnoses, access to care, and public awareness. Zeller's book, The Headache, is available now. You can find more information about Tom Zeller, Dr. Amal Starling, and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. Our writer-producer this week is Polly Hansen. Our lead producer is Kristen Farah. Our executive producer is Amira Zaveri. I'm Elizabeth Westfield.